we will talk more about how the heart beats and all of these lovely things, right? Um, I should have heart. I think I mentioned it before, but just to make sure, we should have hearts to look at. There should be enough there that some of you will be able to do dissections as well. That should be interesting. I'll talk you through the dissection, of course, right? But the lab itself is going to be comprised of heart, interior, exterior drawing. So please bring white paper and pencils, of course. It will also be drawings of the artery and vein as well. So you're looking at 4 drawings to do, with the interior of the heart being the most complicated one. All of which need to be signed off on the day, right? Generally speaking, that means you will need to finish most of the drawing itself and put a scale bar on it, and I'll sign it and I'll send you home to finish it, right? Then we're going to be doing the blood typing at the end so that we can determine your blood types, right? And we're going to try to do a class table for that one, but we'll see how that one works out. All right, let's continue. So platelets. I think I'd mentioned to you all before that platelets are not cells. I mean, there's a different group, who knows? Platelets are essentially bags made from cell membrane. And these bags of cell membrane are stuffed with different, what we call clotting factors and other things that are required in order for the clotting process to begin, okay? As well as to enhance it. So when it says here, a platelet is a cytoplasmic fragment, right? It's basically saying, I'm not putting recordings anywhere. Anyway, I mean, I guess I can bring some of them come on when I come next week, Tuesday, and y'all can figure out where to put them. All right, so I'll probably do that. I'll put them on a thumb drive when I come next Tuesday, and y'all can sort it out from there, right? Anyway, so cytoplasmic fragments, which basically means in order to make a platelet, the cell that makes the platelet is something called the megakaryocyte. Okay, mega of course means big. Karyon is referring now to cytoplasm, so it's a big cell full of cytoplasm, right? So this big cell full of cytoplasm actually sheds the platelets. Now, as it mentions here, so that's the megakaryocyte. As it mentions here, your platelets have an average diameter of 4 micrometers, and they're 1 micrometer thick. So they're smaller than red blood cells, and they're even thinner than red blood cells, right? They are not cells at all, remember. So there's no nucleus, no endoplasmic reticulum, no mitochondria, nothing. It's just a bag, essentially, right? And the platelets themselves don't last very long. As it mentions here, platelets last around 9 to 12 days. Now, even though they last 9 to 12 days, they can't last that long. Once the platelets get old, your body removes them from circulation using white blood cells in the spleen. All right? They cannot remain in the blood when they're old, because, as you all know, old is equals brittle. Right? How often have you seen a little old lady who trip and drop and all of a sudden her bones explode? Imagine a poor platelet, old and shaky. The platelets will break open when they get too old and spill a clotting factor into the blood, which means, of course, old platelets can cause blood clots to form in your bloodstream. So they can't stay there. Once they get to around the age of 9 days or so, your spleen removes them. Okay? All right. Now, when I was showing you the slides on Tuesday, Wednesday, whenever it was, I showed you that there were platelets on the slide here. So you've seen platelets before. So this just gives you an idea of the size of a platelet in comparison to the size of your red blood cell, right? You can actually take the platelets and just put it in the depression in the red blood cell. That's how tiny these things are. So, remember what I said, platelets, they release clotting factor. And in addition to that, one second, this diagram has gone wandering. In addition to clotting factor, right, which of course aids in the clotting of the blood, platelets do something else that most, and again, y'all are nurses, maybe you're all familiar with this. Platelets form plugs, all right? So what do you need to plug, and how is that different from what do you call it, a clot? Here's the thing. A blood clot requires the formation of fibrin and trapping blood cells, all of which get shoved into an open wound that will stop further bleeding, okay? Clots are basically used when there's severe trauma. It gets, and you need to stop the bleeding ASAP. But if you get like a little tiny little break in a blood vessel, right? The whole thing doesn't explode, but maybe a piece of it chip out. And it's big enough that the blood cells can start oozing out. You do not form a blood clot for that, right? Instead, you form what is called a platelet plug. Essentially, all a platelet plug is thousands and thousands of platelets get attracted to the area where you have your little leak, and they shove themselves into the leak, and then they swell up, right? You ever see movies where, like, when people get shot, or maybe y'all in the hospital, maybe see somebody coming there with a shot, a stab or a shot, and the doctor will pull gauze and shove the gauze down into the wound, which looks very unpleasant. And of course, as the doctor just keeps shoving gauze until the gauze absorbs enough blood and swells up and blocks further bleeding. All right? So I want you to think of the platelets like the gauze just shoving into the wound. You're packing them in there, they swell up, leak stops, right? But just like the gauze, platelet plugs are essentially only for relatively small wounds, right? Something that is relatively easy to manage. Now, could you do a clot to fill a small wound? Yes, but guess what? Blood clots are dangerous, right? They are why are they dangerous? Very simple. When you trigger clotting, right, and you form a blood clot, in the initial stage of a blood clot, the blood clot is very delicate. Have you guys ever heard the term frangible? Maybe that's a nice new word. It just means it's very delicate. It breaks apart really easily. So as the clot is forming, bits and pieces of it will actually potentially break off and go floating around in the blood. And these bits and pieces can actually block capillaries somewhere else in your body, which can cause all sorts of other problems. Or in the cases where people have excess platelets in the blood, you can form massive blood clots. And these massive blood clots can once again break off and go floating around through the blood. And these massive clots don't just block capillaries, they can block major vessels. And that, of course, can very much kill you. Right? I remember this case that happened in the US about 5-6 years now. They had this business, this was before COVID, obviously. He had this business man who flew from the US to China. They were doing business in China, right? Now, he was not one of the high-powered executive types. He was a low-level manager type. And they shoved them in coach, coach, yeah, economy and coach and business class and all kind of things. This guy was in his 50s and he was a tall fellow. He was over 6 feet tall. And they rammed him into this little tiny seat. And he was wedged in that seat for 13 hours. Right? And during that time, the pressure his legs were under was so great that platelets in his blood broke open, right? And the clotting process formed. And he couldn't move his legs around because of he was wedged into the seat. And as the clotting continued, the clot got bigger and bigger and bigger, and there was not even strong push from the bloodstream to kind of break it to pieces. Now, so he was very, very uncomfortable. Now, once he finally got to China and he unwedged himself from the seat and started walking towards the terminal, as he was walking now, his blood now can circulate more easily through his legs and his heart can pump more easily. And he pumped that blood clot right to his brain and had a stroke in the 15, 20 minutes it took him to get off the plane and start walking towards the terminal, right? So yes, clotting is dangerous. So your body only does it when it thinks your life is in imminent danger, okay? So the process of hemostasis is now essentially the process by which we stop the loss of blood, right? So hemo, blood, stasis means stop. So hemostasis is stopping the blood. In this case, it's stopping it from leaking out, right? So as it says, let's look at the major components. So when you first get damaged, remember what I said to you, you don't want to start clotting immediately if it's a small wound. You form the platelet plug first. And if the platelet plug is not good enough, your platelet plug can't form fast enough because the wound is too big, only then will you continue. So if you notice here, you have vascular injury, so the blood vessel gets damaged, right? When the blood vessel gets damaged, you're going to get vasoconstriction occurring behind the damage. Why is that? Because you want to slow the flow of blood going to the damaged area, obviously to control blood loss. So you vasoconstrict behind the damaged area to reduce blood flow. You release tissue factor, and the tissue factors call platelets to the damaged area, right? So the platelets know something is wrong, and basically they're running come, right? They're coming now to find out what the heck is going on. Once they get to the site of the damage, remember what they're going to do. They want to shove themselves in the wound and they want to swell up. But in addition to swelling up, they generate what looks like the little spiky protrusions, right? You ever see one of those little spiky balls that people like use as a massage ball? Or another good analogies, you know when you walk through grass and they have that little round marker stick to your clothes, think of that as a platelet. And you notice how the round marker them stick to each other as well as to you. So the platelets go into the wound and they change shape. So they swell up and change shape into like a sticky marker shape. And this helps to pack them in the wound. And because they have these spiky protrusions, it helps to hold them in the wound. Now, so that's how we go from damage, right, to platelet activation, then platelet plug formation. So the platelets swell up, get spiky, get stuck in, right? And this is primary hemostasis because, of course, this happens every time. It happens first. Now, if the platelet plug fails, right, or bleeding continues, then now tissue factor is going to cause a coagulation cascade, which will lead to secondary hemostasis, along with the platelet itself helping to trigger this to form a blood clot, okay? So remember, you do plug first, and if plug fails, that is when you draw for clots. And why? Because clots are dangerous, okay? So let's look at the vascular, the phase of hemostasis. So the vascular phase, remember the vascular phase, the blood vessels constrict in the area where you have the damage, right? This reduces the flow of the loss of blood. Then now, So that's the vascular, right? Then the endothelial cells now. Remember that your blood vessels are lined with endothelium. As it says there, they contract and expose the basal lamina to blood. What does this mean? It means now in the damaged area here, the endothelium, the lining cells, pull away from the damaged area and they expose these collagen fibers. Why is that important? Because collagen is very attractive to platelets. Platelets love to stick to collagen. So let's go again. The blood vessel gets damaged, starts to bleed out. Vasoconstriction begins via vascular spasm, squeezing down on in the area where the blood is being lost. This slows down the amount of blood being lost. At the same time, the endothelial cells here, which are lining the wall of the vessel, they constrict, they pull away from the damaged area, leaving the collagen fibers, right? Collagen fibers, of course, help to give strength to your blood vessel. But remember now, as the platelets here are moving to the area where the damage is, they come into contact with the collagen fibers and they stick to the collagen fibers. Because for them, collagen fibers are very sticky, right? And even the endothelial cells themselves become sticky as well. But only the ones near the damaged area. So only these here. The other endothelial cells do not become sticky. So the whole idea here is that in the area around the break and in the break becomes attractive to platelets and causes the platelets to stick to everything in this area, right? So remember now, the platelets come in, they stick, they swell up, and they get spiky, right? So as it says here, endothelial cells will contract to expose the basal lamina to blood. Remember that exposes the collagen. And they release now chemicals and hormones like ADP, adenosine diphosphate, and tissue factor, and prostacyclin, and endorphins. These chemicals help to attract the platelets to the damaged area, right? And also makes it easier for the platelets to stick to the endothelium. Remember, only the endothelium near the damaged area, which of course helps to get the platelets in. So during the platelet phase now, that is when the platelets start sticking. So remember, the vascular phase, what's happening? The blood vessels are constricting down to reduce blood flow. The endothelial cells are contracting away from the damaged area to expose the collagen. The endothelial cells are releasing chemicals like ADP and tissue factor, which help to call the platelets come. And it also makes them sticky so that the platelets will stick more easily to the endothelium near the damaged area and to the collagen near the damaged area, right? Then once the platelets start sticking now, they will stick to the collagen and they will stick to each other. And platelets that are sticking are going to release their own factors. So if you look here, so now, here's collagen. Remember what I said, platelets love collagen. So the platelet comes along, sticks to the collagen, right? When it sticks to the collagen, the platelet itself releases factors. So more ADP, remember your endothelial cells release ADP as well. And this other hormone here called thromboxane. And these hormones call more platelets down to attract the platelets. So those platelets will now come to the ones already attached to the collagen. Those have already swelled up and changed shape. And more platelets will come in and stick to the other platelets that are there, as well as to the collagen, swell up, change shape, packing themselves deep into the damaged area, sealing it off, right? So as I says, platelets become spherical and develop cytoplasmic processes. So as I said, they swell up, and then they get the spikes. Those are the processes, right? And then produce chemicals I mentioned already, ADP, which causes aggregation and secretion. So the ADP helps to call more platelets to the area of the damage. And you have thromboxane, which we mentioned before, and serotonin, which help with vascular contraction, right? So they help the blood vessels to narrow and make it harder for blood to leak out. And the platelets also release clotting factors if assuming that they're not able to do their job of stopping the injury, they release clotting factors, which will start the next process. And also mentions platelet-derived growth factors here, which make the growth of the cells in the damaged area faster so that you can close the wound as quickly as possible. It even mentions that calcium is needed for platelets to aggregate, right? I think people always underestimate the importance of calcium in your diet, right? You need calcium for muscle contraction. You need calcium for nervous system transmission, and you need calcium for your blood to clot properly, as well as to form platelet plugs. Calcium is extremely important. It's not an accident that we store so much calcium in our bones, right? So what you're looking at here is a bunch of activated platelets, and you can see their little cytoplasmic protrusions coming out. So this here is a plug forming. All right, so that is platelet plug in a nutshell. So now, remember now, if you cannot plug the wound, right, you're going to need to move to the next step. And that now is the clotting part. So hey, you tried, you failed, now it's time to clot. So it mentions here that, of course, clotting, as you know, is, what's a blood clot? It's fibrin that forms a mesh and plenty of red blood cells in the mesh, all of which get shoved into your wound, right? And that is supposed to, at least in theory, and in practice, obviously, because it happens every day, it stops the bleeding, right? All right. So in order for this clot formation to occur, you essentially have to convert fibrinogen to fibrin. Remember, fibrinogen is the inactive form of fibrin, and it is soluble in plasma. So this stuff is already dissolved in the blood. It just has to be converted to fibrin in order to work properly. So to do that now, there are three ways that are required. We have what is called extrinsic pathway, which is one way of activating clot formation. An extrinsic, which is the next way. So extrinsic, intrinsic. Now the common pathway is called a common pathway because regardless of how you start the clotting process, whether you do it via the extrinsic path or the intrinsic path, both of them have to feed into the common pathway. Let me show you the common pathway. This common pathway here leads to the formation of fibrin, right? The other two pathways are just there to activate the processes within the common pathway. So let's look at the individual processes, intrinsic and extrinsic, in a little bit more detail. Then we'll talk about the common pathway. So let's try the extrinsic. I know y'all hate diagrams like this, but you all have to remember these, right? Particularly since some of the questions you'll be getting will be structured type questions in your in-course test, as well as in your lab quiz, as well as in your final exam. These are the kind of places that we draw questions from, right? I can write a dozen short answer questions or a dozen multiple choice just from this alone, okay? So what happens during the extrinsic pathway? The extrinsic pathway starts with the damaged endothelium So that's the endothelial cells from around the damaged area releasing tissue factor, right? And tissue factor is also called factor 3. Now this tissue factor, once it's released, is going to combine with calcium and another factor that's always floating around in the blood called factor 7. Your liver makes this stuff. It's always there knocking about, right? And they're going to combine to form basically a tissue factor, factor 7 complex. And then this complex is going to activate factor 10. And factor 10 is where the common pathway begins. All right? All right, let's do it one more time. In the extrinsic factor, in the extrinsic pathway, sorry, you start out with a damaged tissue releasing tissue factor, okay, which is factor 3. So the endothelium from a damaged area secretes the tissue factor into the blood. In the blood, in addition to calcium, you also have factor 7, which is made by the liver. These three things, the tissue factor, the factor 7, and the calcium all combine to form a complex, which is the factor 7 complex, tissue factor, factor 7 complex. So all three of these combine to give you this. Now this tissue factor, factor 7 complex, oops. Well, we can use it on this diagram here. Use more than one, why not? So here we have the factor 3 from the damaged tissue. So remember that's tissue factor. Here we have the calcium. Here we have factor 7. All of them combine to give you the tissue factor, factor 7 complex. And then this complex here acts now as an enzyme that triggers the activation of factor 10, right? So the complex activates factor 10. Factor 10 starts the common path, right? And that is extrinsic. Intrinsic pathway is slightly more complicated. If I'm honest, this is a simplified version of it. In the intrinsic pathway, you have factor 12 floating around. When it gets exposed to collagen, it becomes activated. So remember where the collagen is coming from. Collagen is coming from the damaged area of your blood vessel wall. So now the factor 12 comes into contact with the collagen and is activated. Normally when you see A here, A stands for active, okay? So your factor 12 gets in contact with collagen, becomes active. Your activated factor 12 then goes to another factor called factor 11. I think everybody knows the Roman numerals, right? And activates factor 11 to give you activated factor 11 over here. Then the activated factor 11 now goes and activates factor 9, which of course means that you've missed a number, but you know, it is what it is. And then the factor 9 that is activated goes on now with calcium and factor 8, all of which will activate factor 10. And then that bleeds in to the common path, right? So let's go again. Factor 12 is activated by collagen. Activated factor 12, give me a second, Abby. Activated factor 12 activates factor 11. Activated factor 11 activates factor 9. Activated factor 9 activates 10. So you go 12, 11, 9, 10, okay? So intrinsic pathway is 12, 11, 9, 10. Yes, Abby?
Sir, I was going to ask, is it that once factor 12 is triggered by collagen, it's just like a chain reaction going down?
It's a cascade reaction, which is basically a chain reaction. So it's a cascade. So once you turn one on, the rest of these are going to happen unless something blocks it. So you're 100% correct, right? So once 12 turns on, 12 will turn on 11, 11 turns on 9, 9 turns on 10, common pathway starts, right? So like your extrinsic pathway, actually I like this diagram better. You release tissue factor from the damaged tissue that combines with factor 7 and calcium. You get your complex, you turn on factor 10, right? Remember, in both cases, intrinsic, extrinsic, at the end of the day, you're trying to turn on factor 10, okay? Now, once factor 10 turns on, here's now where things start to get more interesting. So, activated factor 10 forms prothrombinase. Now, which is an enzyme. You know, it's an enzyme, of course, because you have the ASC at the end. So the enzyme prothrombinase is going to work on prothrombin. And prothrombin is the inactive form of thrombin, which is a different enzyme. So what you have is one enzyme activating another enzyme, which activates something else, right? So now, the fact that 10 gets turned on forms prothrombinase. Prothrombinase, once it's on, converts prothrombin to thrombin, right? Then the thrombin now is what converts fibrinogen to fibrin. And of course, fibrin is what forms the mesh, and that starts off the clotting, right? But thrombin also activates another factor called factor 13. And factor 13, when it's released, it goes into the fibrin fibers and it joins them together to form a proper mesh, right? So when you turn on the fibrinogen, it forms fibrin strands. Then you turn on the factor 13 and it sews them together to form a net, basically. And that is now when you start catching the blood cells in that fibrin net, and you can then shove them into the wound to seal it. All right. Any questions so far? Cool. All is well.
Yes, sir.
Oh, okay.
I'm not sure if you mentioned it before, but for the common pathway, I mean, for the extrinsic and the intrinsic pathway,
All lead to the common
one
pathway.
or is either one or the other?
No, you can activate both at the same time.
Okay.
So let's say you have a severe wound. Both of them will be running at the same time to increase the rate of clot formation. As a matter of fact, the more damage there is, the faster clotting happens. So let's say you get stuck with a needle or something. You know, it's a minor injury. You might actually feel that might actually bleed longer than let's say somebody you get a cut with a knife. Simply because in a minor wound like that, your body's like, Chuck, we have all the time in the world. There's no need to form a clot. We'll just keep shoving platelets in there until it seal up. But if you get a cut now, a significant cut, the body knows there's no way in hell place to go and fix this. We need to start clotting ASAP, right? Now, once the clot has formed and stabilized, your body gets a chance to essentially fill in the damaged area and start to repair things, right? Now, once that happens, you pretty much don't need the clot anymore, right? And when that happens, you release other factors. Oh, hold on 1 second, there's a question. A small cut will normally take longer to stop bleeding. I won't say heal, but it tends to take longer to stop bleeding. As I said, because it's not considered a major threat. So everybody's like, take extra time, no big deal. Oh, by the way, I should also mention that certain places in your body have a lot of capillaries. So they get damaged in those areas that bleed like judgment. So everybody knows, for example, that if you get scalp damage, if you get a cut in the head, it bleeds like crazy. It doesn't have to be a big wound, but it bleeds and bleeds and bleeds because of all the capillaries you have going to the skin on the head, right? Anyway, we only have a couple of minutes left. So let's introduce the heart. Y'all know these already from CSEC, I'm sure. Just make sure you refamiliarize yourself with them, okay? So what I'm going to do is I'm going to take the last couple of minutes and I'm going to run through what I think you should know already. I'm hoping you know already from CSEC. So let's see. So I'm going to trace the flow of blood through the heart. So just listen for a moment. It should all sound familiar to you. All right, here I go. All right. Let me choose a blue color first. Y'all remember why we use blue on one side and red on the other side?
One for artery and one for vein.
It has to do with the blood. What about the blood?
Is it like deoxygenated?
Deoxygenated
Yes.
blood.
Blue is for
Deoxygenated.
deoxygenated blood. Red is for oxygenated blood. All right.
Yeah.
So your heart, of course, has 4 chambers, 2 atria, 2 ventricles. Blood enters the heart via the right atrium over here, via your inferior vena cava, which is taking blood from your abdomen and legs, and the other is from the superior vena cava, which takes blood from your chest, arms, head, neck. All of this deposits the blood within the right atrium, okay? Now, you also have something called a coronary sinus. This is where blood from the heart tissue itself goes back to the heart, okay? Because you have to remember something. The blood flowing through the heart cannot be used by the heart. There's no way to get oxygen from blood inside here. So you have to move the blood out of the heart and then send that blood to the coronary vessels. I'm sure you've all heard of coronary arteries and coronary veins. This is how the blood gets its own oxygen. So that blood comes back to the heart via your coronary sinuses. So that blood flows into the right ventricle, causing the right ventricle, of course, to swell, right? Now, once the ventricle is sufficiently filled, it will contract. And this forces blood from the right ventricle into your right, from the right atrium, I should say, into the right ventricle. And in order to get into the right ventricle, the blood has to pass through a valve called the tricuspid valve, okay? Tricuspid valve. And the reason it's called a tricuspid valve is because there's 3 cusps, or 3 parts. So 1, 2, and 3 up here, so, right? So that's 3 parts, hence tricuspid. Now, once the blood pushes past into the ventricles and fills with blood, the right ventricle is going to contract. While this happens, blood is forced against the valves, which helps the valves to close. So the tricuspid valve will close under the contraction of the right ventricle. Now, to help this process along, your cusps have these strings connected to them called chordae tendineae, right? And they help to position the valves in the correct position. And they do this with the aid of what we call papillary muscles. You ever see anybody put up a tent? And you know that the tent, to get the tent properly put up, you have to put tension in the fabric. So what do you normally do? You have cord attached to the tent and you pull the cord out and then you, of course, stake it out in the ground so that it has tension in the canvas of the tent. So the purpose of the chordae tendon is to put help put tension in, right? So the papillary muscle contracts and pulls on the choroidal tendon, and it pulls on the back on the valves and tensions them so that they're either closed properly or open properly. They don't close halfway or open halfway, right? So the papillary muscle here is like you pulling on the strings of the tent to tension it properly, right? Now, when the right ventricle, you notice that the right ventricle wall is pretty thin in comparison to the left ventricle. This is because the right ventricle is only pumping blood to your lungs, okay? So when the right ventricle contracts, tricuspid valves close, and then that blood gets shoved out of the ventricles into, through what we call the the pulmonary valve, or the pulmonary semilunar valve. So the blood gets shoved out of the heart, past this valve here, which stops the blood from flowing back into the heart, into what we call the pulmonary trunk, right? That's the pulmonary trunk. The pulmonary trunk splits into pulmonary arteries, right and left. Why right and left? Because you have right and left lungs, okay? So for some weird reason at CSEC, they hardly mention the pulmonary trunk. They just say, oh, blood leaves the heart, the right side of the heart, and goes into the pulmonary arteries. It does not go straight. It has to go to the trunk first, okay? And from the trunk, that blood, remember, goes to the pulmonary arteries, which then carry that blood to the lungs. Now, also remember, pulmonary arteries are special. They are the only artery in the body that carries deoxygenated blood, right? All other arteries in the body carry oxygenated blood. That said, all arteries carry blood away from the heart. So pulmonary artery carries deoxygenated blood. Only one that does it, but it is still carrying blood away from the heart, just like all the other arteries, okay? So the blood leaves the heart, goes to the lungs, gets nicely oxygenated, and then that blood comes back to the heart via the pulmonary veins. Now, the pulmonary veins are the only veins in the body that carry oxygenated blood. All the other veins carry deoxygenated blood. But all veins carry blood to the heart, right? So if I ask you to tell me something true of all arteries, you can say all arteries carry blood away from the heart. What's true about veins? All veins carry blood to the heart. Pulmonary veins have oxygenated blood in them, which is weird for a vein, but all the others carry deoxygenated blood, right? Pulmonary arteries carry deoxygenated blood, which is weird for an artery. All the other ones carry oxygenated, okay? Now, let me briefly mention why this is. The arteries are much more structurally tough than veins are. They can take more pressure. When the right ventricle contracts and you end up shoving blood into the pulmonary arteries, the pulmonary arteries have to be strong enough to absorb the pressure without popping like balloons. A vein couldn't manage that. Therefore, you need an artery to carry that blood to the lungs from the heart because of pressure. There's too much pressure generated by the right ventricles, hence must have an artery. But if that's the case, why do you need a vein to come back? Because the blood coming back from the lungs is moving very slowly, right? Whereas the blood leaving the heart is being squirted out quickly. And why is it coming back slowly? Because the further you go away from the heart, the less impact the pressure of the heart has on the flow of blood. Now, the same amount of blood has to leave the heart and come back. So if you pump out 4 liters per minute out, you have to get back 4 liters per minute. Since the blood is going more slowly coming back to the heart, you need a bigger vessel to carry the blood. So even though it's moving more slowly, it carries a bigger volume, right? It's like you trying to fill a bucket, right? I give you a teacup, it takes you a while to fill a bucket, right? If I give you a 1 liter mug, you fill the bucket faster. Now, so the veins have a larger lumen that can carry more blood. So even if the blood is moving more slowly, you still end up getting the same amount of blood you lose. Okay? So same amount of blood leaves the heart, same amount comes back. That is why you need pulmonary veins here. Arteries are too narrow in the lumen for this. You need a big lumen for the slow moving blood. All right. Now, once that blood enters the left atrium, of course, you fill the left atrium, and you have another valve called the bicuspid valve or the mitral valve. Bicuspid has 2 cusps. 1, 2. So there are 2 flaps that join together to seal, right? So when the left atrium contracts, it pushes blood through the bicuspid valves and pushes that blood into the left ventricle. Now I'm going to mention something I haven't mentioned before here called the trabeculae carneae. When you look at the heart next week, you'll notice that the heart has all of these ridges and protrusions inside, which don't seem to serve any function. But of course, they do serve a function. They are there to prevent the heart tissue from sticking to itself. When you're in a lab, if you rub your fingers on the inside of the heart, it's smooth, right? Think of what happens when a plastic bag gets wet and you put it on a kitchen counter. The plastic bag sticks easily to the kitchen counter, right? Because the plastic bag is smooth and the water makes it stick easily to wet surfaces. The endometrium is the same way. When the ventricles contract left and right, they squeeze down and the walls touch each other, right? If there were no trabeculae carneae there, they were just stuck on each other. So you'd have like suction going on. So it'd be hell to pull them apart. But the trabeculae carneae, breaks up the surface. So when the heart contracts and the walls squeeze down and touch one another, they can't stick to each other properly. So they can relax and get filled again. So the trabeculae carneae stop the heart walls from sticking together, right? So the ventricles contract. In this case, the left ventricle, which is much thicker, of course, contracts, pushes blood up past the aortic semilunar valve, which we're not seeing here, into the aorta. And the aortic semilunar, of course, stops the flow of blood back into the ventricle. And from there, of course, that blood goes to the rest of the body. All right, it's after 5. Let me stop here. But as I said to you, what I just said should sound, I'm hoping and praying, very, very familiar to you, right? Hoping and praying. I'm going to assume that's a yes. I will run back through it again, of course, next week if there's time. So, all right. So remember now what we do next week, real quick. In class, we're going to talk about the structure of the heart, right? As well as how the heart pumps. We're also going to mention some of the major blood vessels associated with the heart. We're also going to talk about the structure of arteries and veins as well. See if we can do that in 2 hours. We also have the tutorial for the heart to go through, right? Depending on time, we'll see how it goes. But we need to finish up the blood tutorial first. Because now that we've done the platelets and blood clotting part, you should be able to answer the questions from that part of it, right? So I can ask you those questions. And we're going to see if we can get to, well, we're going to see if we can finish the slide next week, Tuesday. Let me see how many slides we have left. Slide 109. We are one, so